Dr. Sullivan from the East Coast is now going to bring on where we stand with targeted agents, how it's going to fit in our therapeutic paradigm, and whether we can all get along and utilize both targeted and immunotherapies, and where and should we manage to place them? Where should we manage to sequence them? The main theme that Dr. Pirro began with. So with that, I'd like to introduce a great researcher, phenomenal doctor, and an even better friend, Dr. Sullivan. Talk to us about targeting.
Thank you so much, Dr. Hamid, and I'd like to thank AIM at Melanoma as well for putting on this wonderful program and for allowing me to be part of it. So I'm going to share my screen now. And here we go. So I've been tasked to talk about targeted agents and was given the title of Today and Tomorrow. So what I'm going to do, my slides are somewhat complex, but I'll try and speak in less complex language, just try and give you an idea of what we're doing, why we're doing it, where we are now, and where we are going. And here are my disclosures. So when we think about targets, in truth, any drug is targeted. All drugs have the immunotherapy drugs that you've heard about target PD-1 or CTLA-4, some target PD-L1, some target all kinds of specific things. So all drugs have targets. But when we think about this in cancer and we use the word or the phrase targeted therapy, we tend to think about drugs that specifically block either a protein that's causing cancer or a pathway that's activated by a protein that's causing cancer. And so on this slide, what I've shown on the left is data from what's called the Cancer Genome Atlas. And this is a large group of drugs that have been, or not drugs, sorry, of investigators that got together and decided we are going to do testing on tumors and we're going to do it across a whole bunch of different types of cancer, and we're going to identify how often we see certain changes in DNA. And so in the middle, it sort of says age subtypes, and then they have all of these names of stuff, and those are names of genes that are mutated. And so shaded in red, about 50% of skin melanomas have a mutation in a gene called BRef. And on the right, that's listed as RAF and has these three arrows going to this thing called MEK. In the middle, that's shaded green, is RAS mutated. Most commonly, there's a subtype called NRAS. Shaded in blue is something called NF1. And then the fourth category that's not shaded at all, we call it triple wild type. And what's important to the right in the bright red are these genes that can commonly be mutated in melanoma. Genes like RAF and RAS and KIT and GNAQ and GNA11, these are all what we call oncogenes, which means if they are turned on, it causes cancer. And then there are genes, and these are mostly in gray, which when they are turned off, they cause cancer. And those are called tumor suppressor genes. So their role is actually to control and regulate the development of cancer. And in this scenario, when we're talking about targets, what I've just kind of boxed off or rectangled off are proteins in this pathway called the MAP kinase pathway. And they include RAF, MEK, and ERK. And we have drugs that can block some of these. And so I'm going to tell you a little bit about that. So for the bulk of this talk, it's really going to be talking about what does targeting this pathway do, and what types of effects can that have. And so here we go. This is the treatment landscape for melanoma right now in 2011, I'm sorry, 2011, sure, 2021, and highlighted in red are the targeted agents today. And so these include BRef inhibitors like vemurafenib and dabrafenib and encorafenib. They include MEK inhibitors like trametinib and cobimetinib and binimetinib. And they can be given as single agents or combinations, and there's even all the way to the right on this slide, a combination with an immune therapy. So what's been, this slide will summarize about a decade's worth of work, but what's clear is that blocking BRaf and MEK together compared to blocking BRaf together leads to improved outcomes. And this is using the metric of progression-free survival, which means when you start treatment, how soon after starting does the disease grow? And showing improved outcomes with dabrafenib, trametinib, vemurafenib, cobimetinib, and encorafenib, binimetinib compared to single-agent BRaf targeted therapy. And based on this, the standard treatment, if we're thinking about BRaf targeted therapy, is a BRaf inhibitor plus a MEK inhibitor. Either one of any of these three combinations. Long term, what we're seeing is that about a quarter of patients will not need another therapy. They can stay on the BRaf inhibitor through 3 years, and then that goes to about 15 to 20% at 5 years. So there's diminishment of benefit over time. If we're just looking at, can we predict who those patients are going to be? Patients whose blood LDH level is normal at the time of treatment have better progression-free survival. It goes up to about a quarter of patients who have normal LDH, particularly with the combination of dabrafenib, trametinib. And then if we fold in another criteria, which is basically limited sites of metastatic disease, so only spread to 2 or less sites, and have a normal LDH, then about a third of patients have long-term benefit at 5 years from treatment with BRef and MEK inhibition and can stay on that treatment. In terms of whether patients survive if they initially start these drugs, to the bottom right, over half of patients are alive if they have a normal LDH and have less than 3 disease sites at the time of starting therapy. And that's comparable, and I'll say, how does this compare to immune checkpoint inhibitor? That's comparable to some of the immunotherapy data, at least that subset of patients. But if you look at all patients, it seems pretty clear. In red, I've circled the targeted therapy. In yellow, I've circled the immunotherapy. It took me about 10 minutes to get this orange line to overlap, so it looks nice and pretty. But the bottom line is immunotherapy seems to be associated with this longer. I like progression-free survival as something to look at because it means that you haven't needed to go on to something else and your disease remains under control. And the nice thing about progression-free survival, particularly with some of the immune therapies, is that that often is durable off of therapy, whereas most patients who go on BRef targeted therapy need to remain on BRef targeted therapy during once they start. So what do I do for a patient with BRef mutant melanoma? We have 2 options, just like there's 2 options in the adjuvant setting, which Dr. Weber just talked to you about. There's two options in the metastatic setting, but I don't think it's an either-or choice. And honestly, some patients will start immune-targeted therapy and go on BRef-targeted therapy. Some patients will start on BRef-targeted therapy and then go on immune-targeted therapy. I'm not going to get into the concept of some patients in the adjuvant setting will receive immunotherapy and then can they get BRef targeted therapy for sure, or patients in the adjuvant setting may start with BRef targeted therapy and then they may have benefit of immune targeted therapy later. So it really is a lot of what we're doing now is trying to sort out who should start with what, and it can span across the different types of settings that we see patients with melanoma. There are actually a few randomized trials trying to sort out whether there's a right sequence for patients, or ideally doing these studies and then identifying if there are subsets of patients who may better benefit from starting one type of therapy than starting another type of therapy. There's one of these trials that actually has some data associated with it, and this is called the Succumbit study, and it randomized patients to receive BRef targeted therapy combination, so that's encorafenib and binimetinib is the BRef and MEK inhibitor, or an immunotherapy combination, ipilimumab and nivolumab, or a sandwich, which would essentially be started encorafenib and binimetinib, took it for 8 weeks, then switched to ipilimumab and nivolumab. And then in each of these arms, at progression, patients would switch to the regimen that they weren't on. So in arm A, encorafenib and binimetinib patients would switch to ipi and nivo. In arm B, ipi nivo patients would switch to onco-bini patients. In arm C, because patients went on to ipi nivo as part of the sandwich, then at time of progression, they would go on to ipi and nivo. And ultimately, what we see with the preliminary data is that we're not sure what's the best regimen. So if we look at this progression-free survival, there's differences early on, but as we get further out, all of these curves seem to be converging at the same number. And so it's possible that there are advantages to certain regimens to begin with, but ultimately it may not matter what you start with. Duration of response, we know that ipi and nivo is associated with a longer duration of response. I showed you that a few slides ago in terms of durability of benefit, but it again doesn't mean because the response rate is probably less than it is with some of these other regimens that it's the best regimen. And this is trying to look at basically measuring time to the second progression, because patients could progress on one and then progress on the other. And there may even be some value to this sandwich. I think it's too early to call that. It's very preliminary, but the bottom line is we're doing studies to try and figure out what's the right sequence of BRef targeted therapy or immunotherapy. And to summarize where we are today, 3 regimens, better than single agent BRef inhibitor. The tolerability, which I didn't mention, is actually quite good of these 3 combinations compared to single agent therapy, which is a little bit different than the combination of immunotherapy versus single agent immune therapy, which combination immune therapy tends to be more toxic than single agent immune therapy. So not the same with BRef targeted therapy. A subset of patients remain progression free at 5 years. And there's now prospective randomized data emerging, although it's not clear yet if there's a major difference in outcome in BRef frontline BRef targeted therapy versus frontline immunotherapy. Okay, one other idea is, well, what about just adding it all together and combining BRef targeted therapy and immunotherapy? There's a rationale for this. Basically, when we treat patients with BRef targeted therapy, we see changes in the immune environment of the tumor that makes us think it would be more likely to benefit from immune therapy. So this is antigen expression is just the immune system may be able to recognize the tumor better. Decreasing immunosuppression means that the tumor environment may be more likely to be attacked or allow for attacking the tumor. Increasing T cells means there's more immune cells in there. Increased T cell clonality means there's more types, more diversity of immune cells in there. And increased PD-L1 is usually the response of the tumor to the immune cells. And again, all of these things we might predict would be associated with better outcomes with PD-1 inhibition. So there's now been 3 randomized trials, again, looking at progression-free survival of triplet therapy, which is pembrolizumab, PD-1 inhibitor, dabrafenib, trametinib, BRef, MEK combination versus a placebo plus BRef and MEK combination. And what we see is that in the analysis, it didn't show a major difference in the curves initially, and then over time these separate. But from a statistical standpoint, they used up all of the power of analysis for that first thing. So this didn't reach a statistical significant outcome, even though it looks like triplet therapy is better over time. This is another study. Atezolizumab is a PD-L1 inhibitor, cobimetinib and vemurafenib are MEK and BRef inhibitors respectively. This randomized patients to the BRef and MEK inhibitor versus the BRef and MEK inhibitor for 4 weeks, followed by a triplet therapy. There was more toxicity with the combination of 3 drugs versus 2 drugs, and that was also true in that trial that I mentioned prior to this slide. Here, there was a separation in terms of the progression-free survival, and this time it did meet statistical significance. In terms of the separation, it's actually pretty similar to the separation that we saw in that other study. And there may be an early separation of patients actually living longer who received 3 drugs to 2 drugs, although it's too early to tell that. Here's the third study of a BRef MEK inhibitor combination, again going back to dabrafenib and trametinib as the BRef and MEK inhibitor. Spartalizumab in this setting is the PD-L1 inhibitor. Again, a separation of these 2 curves. Green is the 3 drugs, gray is the 2 drugs. But it didn't meet statistical significance. And again, it looks like there may be a little bit of separation in the curves looking at who's alive and who's not for the triplet versus the doublet. And so to summarize triplet therapy in this today, I would say that it's relatively safe to give 3 drugs, although more toxicity with 3 than 2. There are now 3 randomized studies showing similar, what we call hazard ratio, which is separation of those curves. So sort of a numeric a number ascribed to the separation, the visual separation of the curves, but only one of them was statistically significant, but they're all pretty similar. However, while one drug regimen is approved, and that's the vemurafenib, cobimetinib, atezolizumab study, the others haven't been. And the future of triplet therapy is really not clear as of right now. We have it available to us, but we don't know how best to use it. So how about triplet combinations for tomorrow? Well, this is the phase 1 study of that triplet that actually got approved. I mentioned that we actually give the doublet first, the BRef and MEK inhibitor first for a month, and then we switched to all 3. The reason we did that is actually that was the only way we could get that into patients. It was too toxic to start with all 3 drugs at once, and Dr. Hamid knows this well. He was a major part of this study. We saw high response rates. Patients did well. Many patients had controlled disease for a long period of time. What was interesting is because we had that run-in period of the BRef, and then there's also another single agent, vemurafenib, then adding the PD-L1 inhibitor, we could actually see the effects of the therapy on the immune populations. We actually saw increased T cells, both CD8 positive T cells and CD4 positive T cells into the tumor environment when we were treating for that 1 month with the BRef targeted therapy. But interestingly, T regulatory cells, which are actually suppressing the immune attack against the cancer, seemed to go up a little bit when we just used vemurafenib, and went down slightly or didn't change much when we used the combination. And so we thought that maybe the fact that there are changes in the immune environment might allow for us to study this in a more rigorous way. And so we've actually begun to do this. And so this is a clinical trial. I sort of say this, that today's clinical trial should inform tomorrow's. And this is a trial where we're giving a lead-in of a BRef and MEK inhibitor combination, dabrafenib and trametinib, then we add pembrolizumab, and then we stop the dabrafenib and trametinib and then go on to just the pembrolizumab. And we're asking a few questions. Does abbreviated therapy lead to better outcomes? Are there baseline states of the cells in the tumor that are associated with benefit from the 3 drugs? And does changes in the immune cell populations predict who will benefit from combination therapy? And then does BRef and MEK inhibitor therapy impact the memory cells, the cells that may stick around for a long period of time, be associated with long-term benefit? I don't have data to show right now, but we're doing lots of interesting analyses on these tumors that we're collecting on patients. And hopefully, not only will we perhaps identify whether this approach is a good idea or not a good idea clinically, but perhaps we'll be able to identify either baseline characteristics that help us predict who's going to do well with this type of approach, or as equally or more importantly, new targets that we can add to make this type of therapy work even better. The last thing I'm going to talk about is building upon the BRef MEK inhibitor backbone. I showed this before. Apoptosis, which I've circled here, is the way that cells can die. It's a normal process, but it's also a process for which, when we give therapy, it's a way that cells can die. And so if we could tip cancer cells closer towards death, we can get greater reduction of tumors and maybe even closer to curing patients with targeted therapy. I'm not going to go into this in great detail, but the family that I'm talking about, that I will be speaking about, is called the BCL2 family. It's a group of proteins that essentially battle over whether to activate or prevent the mitochondrial cell death pathway. And it really is a battle between how many of these various proteins are there and whether they're interacting with each other and preventing or causing the activation of the pathway, which then leads to the death of the cell. We've shown that levels of the proteins that block cell death are actually inversely related to benefit with BRef targeted therapy. We've actually shown that BRef targeted therapy modulates a lot of these values of both those that trigger cell death and those that prevent cell death. And we put it all together and have thought of that, oh, there may actually be a really good drug that could be useful. And this drug is called navitoclax. We've done work in cells and in test tubes. We've done work in animal models, and we've now brought this forward into humans. In Brown are patients with melanoma who've gone on the first trial of the 3 drugs. And we've been showing that it may actually be a useful approach, found it's tolerable, and we're actually moving forward now into this randomized phase 3 trial. And we've actually accrued 37 out of 50 patients across about 10 to 12 sites at various sites across the United States. So this is an example of a triple regimen that's not immunotherapy at all. It's just targeted therapy. I'm going to skip over this, but it's another triple therapy. I'll keep this up because the first trial was called the BAM trial. And so the second trial, called the BAM2, again, is 3 drugs versus 2 drugs. And the idea is, can we give drugs that actually make the immune cells die more readily when we give 3 versus 2. With that, I think I'm going to say a final word about oncogenic targets, but I will go through this and just finish with this. A subset of patients have prolonged progression-free survival and overall survival in patients treated with frontline BRef targeted therapy. Triplet regimens show consistent separation of progression-free survival, but the optimal use of these combinations is unknown. Alternative triplet regimens are being pursued, and that was the BAM study, as well as our targeting the BCL2 family. And then what I didn't show, but can state here, is that targeting other of these oncogenes that are mutated have been frustrating and challenging, but efforts are ongoing. With that, I'll thank you with your attention. I look forward to the question and answer session later. Thank you.